This is how to complete your basic bedside assessment. So as you pull up your checklists that are located within your Blackboard shell, you will have a checklist entitled Basic Bedside Assessment. This is something that you will do with every assessment. We're going to add some things as we learn to specifically assess certain body systems, but at this point, let's just go through the basic bedside assessment. We're always going to knock when we go in. We need to introduce ourselves and let the client know why we're there. What are we going to be doing and what will it entail? We need to address their orientation, so we'll ask their name, we'll ask where they are, and if they have an idea of what time it is. We're not asking time such as on the clock or date such as what is on the calendar, because when you're in the hospital, those things can be very easy to forget because days tend to run together. So asking them what season it is or what meal they just ate, etc. We could also include why are you here, or what brought you to the hospital or to the clinic. This would identify the situation. So we can document that as alert and oriented times 3 if we're doing name, place, and time. If we're including the situation, that would be alert and oriented times 4. And you'll notice that to the side, I have put what you should be documenting. That's in parentheses. Then we move on to our vital signs. Vital signs will include blood pressure, heart rate, respiratory rate, the oxygen saturation, their temperature, and their pain level. Now, if you do not have an oxygen saturation probe at your home, that's fine. Just identify that you're placing a clip on their finger to get their oxygen saturation. If you do not have a thermometer, then I want you to identify that you are obtaining the temperature. You can obtain everything else because in your red lab bag or skills bag, you have received a sphygmomanometer or the blood pressure cuff, and you should have a stethoscope. So you will manually obtain a blood pressure every week for your assessment. You will manually palpate the heart rate. Do not get a heart rate from an SaO2 probe. These are frequently inaccurate due to a variety of reasons, and I have listed that in your presentations. So if you have the opportunity, palpate that pulse manually. In addition, when you're palpating or you're obtaining the blood pressure manually by pumping up the blood pressure cuff and listening with the stethoscope, you're training your ears and you're training your fingers to be able to hear and feel these things, even when they're very faint or difficult to obtain. And this is a vital skill that nurses need to have. So please do this manually. Then you're going to obtain their pain level. Not only the level of what it is, you need to know what it is on a scale of 1 to 10. Nurses need to have measurements. And if we have measurements, then we can compare from one assessment to the next. Is it worse? Is it better? Am I seeing a trend here? Because it's going to help identify if something in particular is going on with your client. So then we have our stethoscope. We need to auscultate. We're going to auscultate the heart sounds. For this course, excuse me, you only need to auscultate in one place, and we're listening for the rhythm. So we're listening for two things. We're listening for the rhythm. Is it regular or irregular? That's all you need to document. Then you're also listening, do I hear the S1 and S2 sounds? In other words, when I am listening to the heartbeat, am I hearing the lub dub, lub dub? The lub is the S1, the dub is the S2. That is all you need to document on your heart sounds. When you move to the lung sounds, you need to be auscultating in at least 6 places on the front and on the back. You'll find those locations outlined in your presentation for respiratory. You will be listening on the right side, then move to the left side. Go down, listen on the left side, listen to the right side. Go down, listen to the right side, listen to the left side. You're going to do that once again, anterior, the front, posterior, in the back. So at least 3 places on each side. Then you're going to document, what do you hear? Is it clear to auscultation? If so, you can document CTA, clear to auscultation. Times how many lobes? Well, there's 5 lobes in the lungs. Even though you are listening in 6 different areas, there are only 5 lobes. So you can put CTA times 5. If you hear wheezes, you hear bronchi, you hear diminished breath sounds, you need to document where you are hearing that. Is it the right upper, middle, or lower lobe, or the left upper or lower lobe? So document where you're hearing it. You could also put bilaterally if it's in both sides. You can put bases if it's in both lower lobes. So just make sure you're identifying where you are hearing the abnormality. Well, you have your stethoscope in your ear, then you need to draw that line right through the middle of the umbilicus or the belly button. So we're going up and down, and then we're going across. So we're making 4 areas. Those are what we call quadrants. We're going to listen in a clockwise manner. You're going to listen to each quadrant for at least 15 seconds to identify if you're hearing gurgling. If you're hearing gurgling, then you have bowel sounds. Excuse me. When we get to the assessment on abdomen, we'll be talking about how many bowel sounds equal active, how many bowel sounds equal hypoactive, and how many bowel sounds equal hyperactive. So at this point, you're just basically listening. Do I hear bowel sounds? If so, they're active times 4. If one area you do not hear bowel sounds, you need to listen for at least a full minute, if not longer, to determine, am I just hearing really slow hypoactive bowel sounds or not? You're going to note the intensity, the pitch. Sometimes it will be really high pitched, and the frequency. Going back to the auscultation, if you hear irregular heart sounds, you need to be counting the heart rate for a full minute. If you hear irregular respiratory sounds, so when you're auscultating the lung sounds, I did not mention that you also need to document whether they're regular or irregular. Then you would also listen for a full minute. So let's review this particular slide. I'm knocking. Hi, my name is Miss Taylor. I'm here to do your assessment. Can you give me your name? Can you tell me what season it is? And can you tell me where you are? Why did you come to the hospital today? Okay, I'm going to get your blood pressure. Now I'm going to get your heart rate. And as I get the heart rate, I'm also going to count the respiratory rate. If I tell the client that I am counting their respirations, then it's going to allow the client to unintentionally alter their respiratory rate. So we usually do not tell them. I will tell you that when I did the assessment demonstrations, that I told the client I was counting the respirations, but that was just to alert you, the viewer, that I was doing that. I'm going to get your temperature now. Can you lift up your tongue, and I'll stick this under your tongue? Okay, and are you hurting today? Okay, can you tell me where you're hurting? And on a scale of 1 to 10, with 10 being the worst pain you've ever felt and 1 being no pain at all, can you rate that pain for me? Okay, so now I listen to the heart sounds. I hear S1, I hear S2, and it's a regular rhythm. I'm going to listen to the lung sounds, 6 places in the front, 6 places in the back. Lung sounds are regular, and they're clear to auscultation times 5. Now I need to listen to your bowel sounds. Is that okay? So I listen to the bowel sounds, starting in one quadrant, working my way around clockwise, and I hear gurgling in each quadrant, so bowel sounds are active times 4. Moving on to the rest of the basic bedside assessment, I'm going to start palpating. I'm going to palpate both wrists. So I'm palpating bilaterally at the same time, and this is the radial pulse. I'm trying to determine the strength of those pulses and the regularity. Are they the same from side to side, or is one side weaker, or is one side irregular? So the average pulse strength is going to be 2 plus. 0 would mean absolutely no pulse is palpable. 1 plus is very weak. 3 plus is pretty strong. And 4 plus would be bounding, really, really strong, like it's going to bounce out of their wrist. So 2 plus is normal, and I could say 2 plus bilaterally. I'm going to check capillary refill in all 10 fingers and all 10 toes. So yes, socks and shoes have to be removed to be able to palpate capillary refill in the toes. I need that blanching of the nail bed to return to its normal color within 3 seconds or less. If they have fingernail polish on, you can actually press the tip of the digit, so the tip of the finger or the tip of the toe, to determine if that blanching returns to its normal color within 3 seconds or less. I'm going to palpate the pulses on the feet. So to find the dorsalis pedis pulse, you see the big toe, you see the second toe. There's 2 bones that are going to go all the way up to about the midfoot or a little higher. This is close to the arch of the foot, but where those 2 bones meet, right in front of them, is where you will almost always be able to find that dorsalis pedis pulse. So again, we're comparing them from side to side. Then I'm going to cross my fingers. I'm going to ask the client to squeeze my fingers as tight as they can. I'm determining their strength. Is it equal bilaterally? And at this point, this is all we need to know. Do we have equal strength? They're not going to hurt your fingers if you cross them. They just can't squeeze hard enough to cause pain. It also addresses their ability to move. If they can squeeze your fingers, they obviously can move. So then you go down to their feet and you have them press on your feet as though they're pressing on the accelerator of a car. Then you put your hands on top of their feet and you're going to have them pull their toes towards their head against the resistance of your hands. If that they're able to move, they have good movement, we want to determine, are they able to press down and pull up with equal strength on both sides. We always want to be observing our client as we are doing our assessment. Is there anything obvious? Do they have any drains? Do they have IV lines? Do they have dressings? Are there any obvious abnormalities? For example, let's say they have an amputation to the right upper extremity. Then we definitely need to be documenting that. Are they diaphoretic? In other words, are they sweating a lot? These are important observations. We're going to then take our pen light and we're going to block the eyes with our hand. We shine the light in one side. We shine the light in the other side. We're looking for equal and reactive reaction of the pupils when we shine that light. It should shrink as we shine the light in there. So we're looking for that constriction, and it should be equal on both sides. I'm not asking you to measure pupil size. We're looking at their skin color, and we can do this by looking at their mucous membranes. This is going to tell us, is it pink? Is it pale? Is it cyanotic? Is it jaundiced or that yellow color? Is it ashen, which is not really a pale color, but it's definitely not pink. It's really kind of an odd gray color. Or is it mottled? If it's mottled, it almost looks like splotches where we have discolorations on the skin. We see this really well in Caucasians, that really light skin. When they're cold, you can actually see mottling, for example, in their legs. Then we look to see if there's edema. The best place to test for edema is going to be on the shin. So we push on the shin and we're looking for any indentation. We're looking to see, does it feel kind of squishy or like there's fluid in the tissues? If there's none, then we document none. If there is indentation, how deep does it go? And your textbook will show you these differences in 1 plus, 2 plus, 3 plus, and 4 plus pitting edema. Or maybe they have edema and it's non-pitting. Or maybe they have edema that is so tight that you cannot indent it at all. And we call that brawny edema. If it's on one leg, we document which extremity it's on. If it's on both, we can document bilaterally. We also need to determine the location of the edema. Is it just in the feet, which would be pedal edema? Is it in the ankles also? If it is, then we would say bilateral ankle edema. Does it go halfway up the shin? Does it go all the way up to halfway up the thigh, etc.? So what is the level of the edema? And then when we're done, we always need to ask our client, do you have any questions? And is there anything I can get for you? Always be in the habit of making sure they have their call light, making sure that the bedside table is close by so they can reach anything they might need, making sure that they're in a safe position. So the bed is lowered. The upper rails may need to be elevated if they are needing that for bed controls or TV controls, etc. Please let me know if you have any questions.